Okay, great. Nice. Hello guys, good evening. Hello Lalit, good evening sir. आपको मेरा सश्वात. Okay, I want a translation, Lalit. I think that's my learning part today. I think I will start every day with Lalit's lecture on Hindi. If anyone can contribute to that, I'll be more than happy. Fine. Thank you, Lalit. Good evening, everyone. Good evening, Lion. Good evening, Nayak. Hope you guys are doing good. And let's start today's lecture. Good evening, Swati. Today we are going to go to the next topic. We are done with inflammation chapter where we saw about acute, chronic inflammation, wound healing, and different morphological patterns of inflammation, right? Okay. Can you guys hear me? Can you guys hear me? Am I audible? Is my voice clear? Hello, Dr. IMSBHU. Okay, I hope I'm audible. Fine. Okay, let's start. Great. Fine. So today we're going to go to the next chapter, hemodynamics, where I'm going to talk about edema congestion today. Will we take it? I think yes, I'm married, Lalit, if that's the question you're asking for. We'll go to edema congestion first, then we'll go to the normal hemostasis, we'll go to infarct, we'll go to embolus, we'll go to shock. Definitely we'll be trying to cover as much as possible. Like I said, let's make sure this year you guys will be reading Robbins, at least the general pathology with me, and let's make every year students start reading Robbins. Fine. Okay, let's go on. So what do you guys understand from the word edema? Today let it be a conversation rather than just teaching. Let's converse, right? What do you guys understand by the term edema? Just answer whatever comes to mind. What do you think edema mean? It's simple, right? So whatever comes to mind, perfect. Like whatever, like an I said swelling, that's enough for me. Edema means normally I'll have fluid or the plasma or the blood, anything inside the vessel. I will not have it outside the vessel, right? That's what normally the blood volume in our body is. Fine, perfect. So now here, edema means the fluid is getting accumulated in the extravascular compartment. That's what I call it an edema. Fine. Whenever the fluid comes to the extravascular compartment, we use the term edema. This is the definition of edema from your Robbins. It's a disorder of cardiovascular, renal, hepatic function, accumulation of fluid in the tissues. It should not be in the vascular compartment. Increase in the intravascular volume is not edema. It should be in the tissues or in the body cavities. Whenever it comes to the body cavity also, I call it an edema. Can anyone tell me one example of body cavity? We use the term effusion for that. Can anyone tell me any one example which comes to your mind when they think of a body cavity? Peritoneal cavity, perfect, right? Your pleural cavity, your peritoneal cavity, your pericardial cavity, all of them we use the term effusions rather than chronic edema. It's a gap, it's a space, right? It's not in the tissue, it's in the space. Now, to understand why the fluid goes outside, we have to go back to physiology. Do you remember your Frank-Starling interactions? The forces? I'm sure you must have had similar image in Guyton or Gannon or A.K. Jain, whatever book you follow. So I have a very perfect balance between a force which comes inside and the force which goes outside, right? The inward force, we call it an hydrostatic pressure, which is actually on the arterial end. The hydrostatic pressure is kind of like a blood pressure. It pushes the blood, and that's what is going to push the fluid outside as well, right? So in the arterial end, I have a force which pushes the fluid outside, and in the venous end, I have a force which is going to pull the fluid inside, right? Sure, Monisha, I'll do it. We'll complete this, and please ask the question later. I'll try to explain compartment syndrome as well, right? Now what happens is, the body is very simple. I have blood coming inside, and the blood will definitely go outside. The reason for me to go outside blood is there are some impurities in the blood that has to be filtered. One is by your kidney. Second route of filtration for me is my lymphatics. So definitely the hydrostatic pressure normally will be a little bit higher so that the fluid goes outside. So I don't want to lose many fluid. So what happens is when it comes to the venous end, the oncotic pressure. Who determines oncotic pressure? Sure, Lalit. Who determines oncotic pressure? There's one guy in our body which says, okay, I am going to be responsible for oncotic pressure. Albumin, right? Perfect. Good evening, Shreya. So albumin determines the oncotic pressure that pulls everything inside. Plasma proteins, albumin. तब तक मेरा हिंदी थोड़ा खराब है, so I'll try to explain in English. Do I have any doubt? Do let me know. I'll try to go slowly and explain it that as well. Fine. Okay. So when it goes to lymphatics, the thing is lymphatics will take few of the fluid and rest of the fluid comes back inside. That's what happens normally. So am I right in saying if there is an excess of hydrostatic pressure, there'll be more fluid going outside? Is that statement right? Swati, Satak, Nayak and Lion. I have more and more and more hydrostatic pressure, the fluid goes outside. It stays outside. Or in other words, if I have very less oncotic pressure, okay, someone is not pulling me inside, can I say the fluid can accumulate outside? Yes. Yes. So I have two reasons of edema now. One, it goes outside, more outside, or someone is pulling less inside. Is there a possibility this guy, if this guy is not working, fluid went outside, ideally it has to go to the lymphatics, lymph node and your ascicos veins, celiac trunk, your lymphatic trunks, everything, right? If that guy is not working, can the fluid accumulate? It can, right? That's all. So the causes of fluid accumulating outside the vessel, an increase in hydrostatic pressure, reduced oncotic pressure, or lymphatic obstruction. That's all. These are the three causes of edema, as simple as that. Again, if you know normal, change it. Little bit change it, becomes abnormal. That's all, as simple as that, right? Perfect, right? Now let's go to few causes where you think the hydrostatic pressure will be increased. Hydrostatic pressure is nothing but the incoming fluid is the hydrostatic pressure, right? That's what we mean by hydrostatic pressure. It's becoming more. Can anyone tell me any condition where the incoming fluid is going to become forceful? It's very simple. We'll have an example like this, then we'll go to real life scenarios. Let's assume there's a tube, okay, where the water flows. A normal pipe, you must have played, you must have water plants, the same pipe, right? Let's go to body very soon, and I'm blocking this pipe. Okay? If I'm blocking this pipe, am I right in saying that the entry pressure will become more? You must have water plants. For you to have forceful water, what do? You close the end of the pipe with a thumb, right? So if I close it, obviously the input will become forceful. Am I right in saying that? That's perfect. So in other words, can I say if there is something which is going to block it at some point of time, the pressure will increase? Yes. So this blocking, I'm going to call it an impaired or reduced venous return. Okay. Now let's compare this to real life scenario. We learn from an analogy and we'll look into this, fine. Whenever there's a blocking of the venous return, it could be your tumor. A tumor can come and block here, or my heart can fail, like Lal said, and your Lion and everyone said, I can have cardiac failure. So cardiac failure is a dual problem. One, the input is coming less, venous return is coming less. If my venous return is coming less, what do you think heart will do? Heart will pump more faster, will push things more faster. That also increases my hydrostatic pressure, right? So anything which increases my hydrostatic pressure could be a venous obstruction or a heart failure, will definitely push the fluid outside. That's first scenario for me, right? Second scenario for us was reduced oncotic pressure. You guys only said that albumin is the reason for oncotic pressure, right? Tell me conditions where you have less albumin. In other words, tell me where was albumin produced? Where was albumin produced? So this is the main concern for oncotic pressure. Perfect. Liver failure, I wouldn't take renal failure as such, but yes, kidney will definitely be a problem, right? In your first year, have you read about something called as an Kwashiorkor marasmus? What does Kwashiorkor marasmus lead to? Kwashiorkor marasmus are protein energy malnutrition. If you remember the picture in Vasudevan or whatever book you learned, if any Kwashiorkor marasmus baby, the limbs will be very thin. What will happen to the tummy? Do you remember the picture? What will happen to the abdomen? Big or smaller? Abdomen will be very big because there is edema in the abdomen. The limbs will become very small. There's no protein, albumin reduces, and the belly becomes huge, right? That's edema. That's ascites. The fluid is in the peritoneal cavity, as simple as that, right? So I can have reduced albumin in case of a liver failure, like you guys said, because liver is going to produce your albumin. Second, I can have albumin can be lost via kidney. We have a disease called as nephrotic syndrome. We'll read about this nephrotic syndrome sometime when we come to renal pathology. Or protein energy malnutrition, where I'm not having enough albumin, right? Anywhere I lose it. Or there are few conditions where I can lose protein via stomach. Uh, a condition called as Menetrier's disease. Again, we'll read this when we come to GIT. I have protein losing enteropathy, I have protein losing nephropathy, and I have PM or a liver failure, right? Lalit, ARF, I won't primarily say it will cause loss of protein. Acute renal failure is a bit different, right? It's very acute. If it's due to some other cause, I'll have edema, but not primarily due to this, right? Okay. So these are the places where I'll have less oncotic pressure. I know causes which cause edema by a more hydrostatic pressure, less oncotic pressure. Who was the third guy who was causing edema? One is hydrostatic, one is oncotic, one was lymphatic obstruction, right? Whatever comes to your mind. Can you hear me? I hope you can hear me. Lymph, I can have lymph obstruction when there is like filariasis. You will read about filariasis. Okay, you're not audible. I can see the voices going properly. Am I audible? Okay, great. Might be a technical glitch. Fine, perfect. Yes, the elephant leg, right? Why do you think I have an elephantiasis? We call them elephantiasis because let's assume the femoral lymph nodes are blocked. Will ever fluid come back? It won't, right? It won't come back. That's why we call them elephantiasis. Elephantiasis is also a type of an edema, right? So I can have obstruction due to filaria, or let's say I'm giving radiation therapy, or I'm doing a surgery, right? I'm doing a surgery. You must have read about breast cancer surgery, right? Can I say breast cancer can spread to axillary lymph node? Is that right? It is right. So when I do a surgery, you will remove the breast parenchyma and also the axillary lymph node. If the axillary lymph node is removed, what will happen to the entire hand? Will it drain? It won't drain, right? So radiation and surgery will again block the lymphatics. When they block the lymphatics, obviously you will have edema, right? So these are lymphatic related edema. Filariasis is very, very rare. Filariasis, once it has got an elephant leg, no, it's very difficult to treat. Initial half I can treat. I will tell you the reason why it's difficult to treat. When filariasis becomes like an elephant leg, you must have seen patients somewhere where there's a huge leg, right? Elephantiasis and elephant leg. At this time, the lymph node will undergo fibrosis. Okay? When the lymph node undergoes fibrosis, reversible, irreversible. Scar is reversible or irreversible? It is irreversible, right? So I cannot treat once it's completely become thick and big, but if I can find out early, I can treat them. Anything which becomes scar tissue will be irreversible, obviously, right? Initially I can treat, but later on I can't treat. But I can prevent. I can easily give medicines. We have lots of programs run by the Indian government. When you go to third year, PSM, community medicine, you will read about them. Fine, perfect. So all these can cause obstruction of the lymphatics. That also can cause edema, right? The role of edema in the chapter of Robbins. One, obviously you can get questions in your Viva and your university exams. Again, that is not my big goal. Our goal is only one from today onwards. The moment you joined MBBS, to see patients and to treat patients, that's all. So I can clinically suspect edema. There are two types of edema. One is called as pitting and non-pitting. How many of you started going to your hospitals? If you started going to your hospitals, go to your medicine ward and then ask your PG, please show me a case of just normal case of a cardiac failure. Just a cardiac failure. Ask them to show you. just go and press. Patients will have edema. Or if you live with your grandparents, how many of you live with your grandparents? Because pitting edema is very common, especially when you're old. When they put the leg and stand or sit for a very long time, what happens is, right? What happens is it will have pit. Right? Its edema is very common there, right? So you press for 5 to 15 seconds, you'll have a pit, right? That's pitting edema. And non-pitting is it will not pit. Generally, lymphatic edemas are non-pitting. Generally, lymphatic edemas are non-pitting. Yeah, and pitting edema, I think of your serious problem. Ascites, also to some extent, I think of pitting edema. Fine. Yes, pregnant women have. Perfect, Swati. Pregnant women have because simple reason. Can anyone tell me why pregnant women legs are swollen? You learn the concept of edema. Can anyone tell me why pregnant women legs are swollen? Yes, in ARF also I can have edema. And Swati gave us an answer. That's right, but can anyone tell me why it happens? The reason for pregnant women having edema is it's a huge tummy. Perfect, that's all right. They have a huge fetus and the uterus is obstructing the vena cava. When the vena cava is obstructed, obviously venous return will not be as good like you and me, so edema happens. But at the same time, when the woman lies down and lifts their leg, that will help. Gravity will help to reduce the edema and it's not permanent. Fine? Perfect. So we know few terms, pitting and non-pitting. Because when you go to clinics, I want to see the cases and say, okay, fine, this is a pitting edema, most likely this. This is non-pitting edema, most likely this diagnosis. Fine? Perfect. And there are a few more clues. Cardiac related edema generally happens on the lower limbs. If heart is the cause, of like heart failure causing edema, generally happens in the lower limbs. I'm not saying only, generally. Renal related edema generally happens in your periorbital tissues. Surrounding the eye, you'll have an edema, right? Or in the face, or you have a facial puffiness. The face becomes swollen. Again, generally, not always. Liver related edema will generally form ascites. Lalit, non-pitting will not pit. Diagnosis, think of lymphatic causes. Lymphatic obstruction being the cause of edema. Right? Okay. So generally when you see patients of lower limb edema or the pedal edema, we use the term pedal for lower limb edema, foot. I think of a cardiac related, surrounding the eyelids and face, I think of a renal related, and ascites, I think of a liver related edema. Okay, these are clues. So when you see patients, I want you to examine, okay, probably this cause of edema. Then do more examination, history taking, and then you can come to a diagnosis. That's all fine. Now let's go to congestion. So what is congestion and hyperemia? That's the second topic today. Hyperemia and congestion. Lalit, cellulitis is different. Cellulitis is an inflammation, right? So just this, no inflammation, just edema fluid, that's all. Okay? Hyperemia, congestion, both mean same. Both means there is redness. Okay? There's redness, that's all. The fluid, the organ becomes more red because of more blood there. There are two reasons for more blood. One, I can have more input of blood, or I can have obstruction of the blood. Right? Hyperemia is more. I'll come to it now. Hyperemia is more, right? So what happens in hyperemia is an active process. Can I say if a patient has inflammation, rubor is common? Rubor, calor, tumor, dolor? Yes. Inflammation related reddening of any tissue, I call it an hyperemia. That's all. That's it. As simple as that. Here, in congestion, it's a passive process. So this is passive. Something is not letting the blood drain properly, like a venous obstruction. I call it in congestion. Hyperemia is like inflammation related. Congestion is like your passive process, right? That's the difference between hyperemia and congestion. Okay. Okay. See, what happens is why lymphatic edema is not pitting is initially lymphatic edema will not be very much pronounced because the fluid accumulating is very little and very slow. That's the first thing, right? Second, what happens is lymphatic edema, when it becomes very pronounced, there will be surrounding fibrosis slowly. So the fibrotic component will not let the pitting happen properly. That's what happens in case of a lymphatic edema, right? Okay. Now let's look at least one case of a passive congestion of your liver. What happens in your liver's passive congestion, right? Let's take, let's first understand the architecture of liver, then we'll go to this. What is the major blood supply of liver? Can anyone answer the major blood supply of liver? It's your portal vein, right? Portal vein is the major blood supply into the liver. Hepatic artery to some extent, right? So if you remember, your liver in microscopy has a beautiful architecture. We call it an hexagonal shaped hepatic lobules. You'll have hepatic lobules like this. And if you remember drawing in your histology or anatomy, you must have called something as a portal triad, right? So I have portal triad in all this hexagonal shaped structure, all the corners of the hexagon, and I have something called a central vein in the center, right? I have in the center of the lobule something called a central vein, and I have in the corners of the lobule something called a portal triad, right? Not at all, Lalit. I studied in a government school, so my English will be actually bad, right? I am never that good in English. Trying to become better. Central vein. Learn Hindi as well. I have in the corners of the lobule something called a portal triad, right? Okay. Now let's see. So this central vein, all the central vein joins and forms hepatic vein. Okay. So all the hepatic vein joins to form, goes to your IVC. IVC goes to your inferior vena cava, goes to your heart. From the heart, everything rotates, right? This is normal, right? Now let's say heart is undergone failure. Let's assume right heart is not pumping. What will happen to the pressure in IVC? Will it be more or less? If the right heart is not pumping, what will happen to the pressure in the IVC? More or less? It will definitely become more, right? So the pressure in the IVC is more. Okay, it's becoming more here. What will happen to the pressure? Blocking, so the back pressure increases, right? So central vein pressure also increases. So the central vein pressure increases, what happens is the blood goes outside because it's draining, right? Why is my voice not audible? I can see my voice in the streaming. Can you hear me? Hello. Okay, great. I'll repeat again. Heart has stopped pumping. Inferior vena cava has more pressure. That will go to the hepatic vein. Hepatic vein has more pressure. That will go to the central vein. Central vein has more pressure. When central vein pressure becomes more, automatically the blood comes outside to the liver because it cannot push the blood properly, right? Okay. No, Lalit, it's not raining here, but I don't know, some problem in the net maybe, fine. So what happens is in the center part of all the hepatic lobules, I'll have bleeding or it will become red in color. So this is called as a congestion. Here there's no increase in the blood supply. Can I say the output is less here? Yes. So this is called as congested liver. It's congestion. Congestion is a passive process. There is no active increase in blood supply, but the blood output is less, right? So it becomes congested here. Yeah, some problem there. And this is called a congestion here. So now this reason for this congestion is heart failure. Heart fails, right? Perfect. So what happens now is, this is in microscopy. I'll have to look at the gross. So when you extrapolate the same finding to the gross appearance of liver. So how liver looks is, let's say, what is the normal color of liver? Have you seen liver in your anatomy? You must have, right? What's the normal color of liver? Can I say liver will have kind of an yellowish color, yellow to brown color normally, right? That's the normal color of liver, right? Let's say normal color of liver, let's shade them yellow in color, somewhat yellowish brown in color. Fine. Okay, this is a close match I got. Yellowish brown in color is the color of the liver. Wherever there is central congestion, what will be that color? Will it become red in color? Yes. So which means, I'm just zooming this again, 1/3 of the liver will become red. Surrounding this part, all the surrounding part will still be yellow, right? I'll have yellow to brown surrounding and center red half, right? So what happens is, to this liver, I'm going to have things like dots of red. I have dots of red and yellow surrounding that, dots of red and yellow surrounding that. This is what happens to the liver, right? All the red here is the congested area, and all this yellowish brown here is the normal area, right? So this looks like a nutmeg. You must have seen nutmeg liver or read about nutmeg liver. How it looks is this, how it looks, right? Now tell me, this area, which I'll mark an area, this area, whatever I have covered in the black one, is normal or congested? Normal or congested? That is perfect, that is normal. And these areas, wherever the red is, right, that is congested. Okay, it's congested red ones, and this one is your normal liver parenchyma, right? Perfect. Lalit, fatty liver looks yellowish, big and greasy, right? Okay, now this looks like a nutmeg. This is actually a nutmeg. Have you seen a nutmeg? If not, go and ask your mom. I don't know its local name. In my mother tongue, it's called as jadikai. So it might be, it's an Indian spice. It's used in biryanis, and that's what I know. It's an Indian spice. The cut surface of a nutmeg looks like a liver, so we call this liver an nutmeg liver. Okay. We call this a nutmeg liver. It looks like a nutmeg, right? There are few things which actually mimic whatever we learn, right? Supari, I don't know if it's supari. Supari is what they put along with betel nut, right? I don't think so that's supari, but supari also kind of looks like that. Fine, the altering color. So it's a nutmeg, so it's look like a nutmeg liver. Fine. There is a seen in chronic venous congestion of liver. This can come in a viva for you. This definitely might be a short answer for you. You might have specimens of nutmeg liver also. You might come across that as well. Fine. Okay, fine, great. So that's about congestion. So what we read today was, one is about edema. We saw the normal and we saw the altered things in normal, and 3 different major causes of edema, and pitting, non-pitting, cardiac, renal and ascitic edema. And then we also saw about the nutmeg liver, that's congestion. Fine. Okay. So last time I asked what to go for. We thought we'll go for MCQs. I'll definitely take MCQs. I'll maybe the next Robbins Read With Me series we'll go with MCQs, right? MCQs for the first 2 chapters, and then maybe we'll go to hemodynamics again. Okay, I'll explain that line. What it means is, have you heard about a disease called as an infective endocarditis? You might have, no? Or let's say heart has a problem called as an infective endocarditis. So what happens here is, let's assume this is your cardiac valves and you have all the chambers, right? So I'm having such a huge lesion in the heart. This is the valve of the heart. I have such a huge lesion in the heart valve. This is an infected foci. Can I say, when the heart keeps on beating faster and faster, there's a possibility that big lesion can break and escape? It can. That's what you remember. Read the second line. When the infected cardiac valve vegetation is the problem in the heart. This breaks and it goes outside. It can embolize. So when this embolus, let's say it goes to my brain, it goes to the brain and it blocks a vessel in the brain. Can it block? It can block. It's not actually a thrombus. They are bacteria. Can this block go into the brain parenchyma and cause an infection? Or can cause an abscess? It can, right? So that's what it says. Septic infarction. It's actually a block but it's actually a septic block. It's not your um, just your clot. It's along with the clot I have organisms, so I can have an infection or I can have an infarction. That's what it means, right? I hope you understood it. Okay, great. So I'll call it a day today. In the next RRR series, I'll try to go with the MCQs. And Gumna means, and we'll continue the RRR series after this again, right? Okay. Me, you are going Lalit or me? I went and I came back long back, right? We'll definitely go with the MCQs in the next RRR session. See you till then. Bye bye. I am at home. I am at Chennai only.